Do you want to go ahead and
Yes,
begin?
yes, I'm gonna go ahead and start and give kind of an overview to Dr. Knaak with some of the work that we've been doing. And so this is the mental health and substance use work group. And we're part of a larger health equity coalition. And some our work actually um, relates to giving voice to folks with mental health and substance use disabilities, trying to work toward health equity, access to care, advocacy, and research. Um, some of the things that we've been working on, more of a longer work that we're doing long term is really our journey mapping, which would give voice to folks with mental health and substance use disabilities. And that journey mapping is really creative. It's actually a map of how they kind of share what their experiences are going in and out different systems of care from residential, outpatient, inpatient, different services, their engagement with providers and so forth. The other thing we've been working on more recently is our system of care emergency detention process. There's been some real challenges with folks with mental health and substance use being able to go quickly from being detained in a hospital or emergency room setting and then going to lower levels of care. Um, some exciting work we've been working with in our stigma reduction survey, which we really wanted to look at the landscape about what is happening within different organizations in terms of stigma reduction. And so we wanted to evaluate things like what type of training and tools they were doing, what kind of activities they were doing. And that's been very good. And that actually spearheaded our desire to have kind of a toolkit, to address some of the gaps we identified from the survey. And then actually that brings us to you, okay, because of the 6 domains that you kind of came up with, addressing, how to engage a system of care, everything from like the social contact, focusing on behaviors, stigma, myth busting. That was one of the things that kind of came up from our discussions was, you know, language, and how people perceived. Also within, he had some really good discussions in terms of multicultural issues, in terms of stigma, historical challenges for folks to access care with folks that are underserved in the community. So those are some of the things we've been working on with our work group.
Wonderful. Thank you, Dr. Williams. So my name is Lisa Albert, and I'm going to introduce our speaker today. Today we're really thrilled to have Dr. Stephanie Knaak, and she's the principal of Insight Research and Consulting. She also works as a senior research consultant with Mental Health Commission of Canada and is an adjunct professor not only at the University of Calgary, but also the University of Manitoba. Stephanie is an international expert in the field of mental illness and substance use related stigma and stigma reduction, and she's published widely on this topic. She's a member of Health Canada's Stigma Stakeholder Working Group and is regularly solicited as an expert content advisor for training programs aimed at mental health and substance use stigma reduction. In 2020, she consulted to the United Nations Office of Drugs and Crime on the development of international guidelines for the reduction of stigma in the context of substance use. And in 23-24, she consulted to the CICAD, Organization of American States, to build recommendations and provide resources for reducing healthcare-related stigma among member states. So, like I said, we are thrilled that she's able to join us today and share her research and strategies in the area of stigma reduction. Welcome, Dr. Knaak.
Thank you so much. Thank you all for joining me today. I appreciate you giving up your lunch hour to be a part of this. And thank you, Dr. Williams, for the introduction and giving a bit of background on the work that you're doing. It all sounds really exciting and encouraging. I'm just going to pull up some slides here and we can get going. There we go. Okay, hope everybody can see that okay. So yeah, okay, awesome, great. Okay, so today, yes, we are going to talk about addressing mental illness and substance use related stigma in healthcare environments. I've got I've got the presentation kind of divided into three mainish sections, I guess four. First, a little bit of grounding in terms of kind of what do we mean when we talk about stigma. So just a little bit of kind of conceptualization work. And then I'm going to talk about three kind of buckets of research that I've been involved with over the last decade and a bit. So our key ingredients research, with Dr. Williams alluded to, which really identifies kind of key components for effective stigma reduction interventions, educational interventions particularly. Then I'm going to talk a bit about our research around trauma resiliency informed practice and how that connects to stigma and stigma reduction. And then lastly, kind of shifting the lens a little bit, moving away from kind of focusing on individual level change, like changes, you know, amongst health providers themselves, and kind of zooming out to look at kind of structures and how stigma is actually embedded in the structures of our healthcare systems and how we can start to address that. And then, of course, question and discussion. Okay. So before I get started, I do just want to acknowledge both the Mental Health Commission of Canada and the Fraser Health Authority, who has, the Mental Health Commission of Canada has funded the vast majority of the research that I'm going to talk about today. So I am for sure indebted to them. And also the Fraser Health Authority in British Columbia, Canada, which is the originator of the Trauma and Resiliency Informed Practice program, the specific program that I'm going to be talking about. So, okay, so conceptualizing stigma. So what is stigma, right? When we talk about stigma, we talk about all kinds of things, right? Stereotypes against people with mental health illness and substance use problems. We talk about prejudice. We refer to negative attitudes. We talk a lot about labeling people, discrimination, unjust policies, laws, institutional practices, and, you know, kind of seeing somebody as less than, right? That is kind of the ultimate marker of somebody who is stigmatized. So all of these things are correct. But we do tend to kind of think about stigma as like a noun, like as a thing, right? But stigmatization is actually, stigma is actually conceptualized as a rather complex social process. And so this comes from primarily the field of sociology, and this specifically from the work of Bruce Link and Joe Phelan, American sociologists. And they describe stigma as a complex social process that involves kind of four main stages, if you will. First, there is the labeling of somebody. That labeling leads to kind of a separation and othering of the person, right? Once you have that separation and othering, you kind of have that space where devaluation can occur, and you can start to see these labeled people as less than, less deserving of care, too much trouble, et cetera, et cetera. Once we have the devaluation, the final and end stage of the process is actual discrimination, which then becomes kind of justified discrimination because it rests on the bed of all of these other stages. So when we think about disrupting stigma or addressing stigma, we need to think about addressing it at all of these points along the process. Okay. So that's kind of one big piece when we think about stigma. The other thing that Link and Phelan discuss in their conceptualization of stigma is they're very clear that these stigmatization processes occur within systems of power, right? So it needs power to exist. So basically, it is institutions and people in positions of power who have the power to stigmatize and to create these processes and keep them going, and then therefore also the power to disrupt and dismantle them. So power is very central to this process as well. The other thing that we talk about when we talk about stigma is we often distinguish between different levels of stigma. And there's kind of three main levels, or four, when you count intersectional stigma as well. But we think often about the first level being self-stigma, so intrapersonal stigma. So that's stigma at the individual level, that stigma that is internalized, where the stereotypes and prejudices and beliefs of the larger culture are internalized by the person who is struggling or who is labeled. Interpersonal stigma is that stigma at the level of everyday interactions. So this is the stigma that exists in the context of provider-patient care. That exists in our conversations that we have with others, the labels we use, the language we use, the behaviors that we enact to others. Institutional and organizational stigma is that level of what I refer to as structural stigma, where there is stigmatization that is actually built into the actual processes and structures of different institutions within policies, models of care, decisions about how to allocate resources, all of those kinds of things. And then the final level of stigma that we talk about is intersectional stigma. And this is more just a recognition that the stigma of mental health and substance use is interconnected with lots of other labels and identities. So other marginalized identities and other marginalized labels intersect with the stigma of mental health and addiction, and then it compounds the experience of stigma. So that is kind of an emerging field of research to focus specifically on intersectional stigma, to understand how these different compounding stigmas and compounding experiences of marginalization affect care, affect experiences, et cetera. Okay, so in terms of the health impacts, we know that there are lots of health impacts related to stigma. It is a big problem. Barriers and delays to help seeking is a big one. And a lot of this is believed to be due to just reluctance to seek help. We know early termination of treatment is another health impact, and this comes from both patients dropping out or being dissatisfied with care, but it also comes from the health provider side as well, right? Kind of rejection by health providers, being discharged prematurely or even turned away from care. And other consequences are basically overall poorer quality mental health care. And also we know that poor quality physical health care is a significant impact. And a lot of the poor quality physical care, we believe, comes from something known as diagnostic and treatment overshadowing, which is the tendency for the kind of the mental illness or the substance use diagnosis to kind of overshadow other kind of physical complaints that patients may have. So it leads to kind of delays in diagnosis and treatment. These quotes here, I think, just illustrate some of what the impact of stigma has on patients for sure, but also on staff. And I think this is a really important point to recognize, is that stigma doesn't just impact patients. It doesn't just affect the trust that people have in the healthcare system. It doesn't just affect their access to care and the quality of care and all of that. It also impacts health providers and healthcare staff. And this bottom quote, I think, really illustrates this point. This is a project that I'm actually still involved in, and in an emergency department here in the city that I live in. And what this nurse was referring to is when we were doing the study around stigma, we were asking, how does stigma show up in the emergency department? Does it show up? And the vast majority of the issues that they discussed were structural in nature, right? They talked about the fact that nurses don't get any training in mental health care. They talked about the fact that the psych beds were these awful places that they described as basically like jail cells. They said the nursing to staff ratio was way higher for mental health patients than it was for physical health patients. So there were all of these structural issues that kind of got in the way of them being able to provide decent care. And it led to a lot of moral distress and burnout. And so yeah, as this person says, it feels awful. Most of us nurses hate it because we know we're doing a really bad job, but I don't think there's anything you can do about it other than potentially just quit your job. So yeah, so I think that's just a really important kind of impact to keep in mind as well, that we are all affected by this issue. So priorities for addressing stigma. So how do we start to move forward? And I kind of see 4 big things that we need to focus on. One is building trust, really trying to rebuild and build trust for patients with the healthcare system. I think it involves a lot of kind of shifting our perspectives and attitudinal change, right? Changing how we really see, think, and talk about mental health and substance use problems and people with mental health and substance use problems. Focus on structural change, and also improve our cultures of caring. And I'm going to talk a lot about that today, how we can improve our cultures of caring, how we can shift our attitudes and perspectives, and a little bit on structural change as well. So the literature basically highlights kind of three big buckets, I guess, of kind of ways that you can approach stigma, certainly at that interpersonal or interpersonal level. Educational programming. But the important thing about educational programming is that it's not about increasing literacy per se. It's actually about changing and shifting attitudes. We need to be challenging our stereotypes and really reframing kind of how we think and talk about mental illness and substance use. The other thing that the research really emphasizes is the importance of focusing on recovery, the realness of recovery, and really kind of emphasizing that recovery narrative. And I'm going to go into more, I'm going to kind of pull back and go into more detail about how we kind of came up with all of this in a few minutes. The other big bucket is social contact, which Dr. Williams referred to. And social contact is using often personal testimonies from people with lived and living experience, and learning from their experiences. It also involves having people with lived and living experience involved in different kinds of committees and advisory boards, and really a kind of, co-designing and co-creating different interventions. Social contact works on that affective domain, right? It works on that personal connection. And the education piece really comes through storytelling. It allows you to see the whole person. And again, we tend to only use social contact when we are able to emphasize that recovery perspective, because again, the recovery piece is really important. The other bucket is behavior change, right? So this kind of focuses on the language that we use, right? The labels and language. Kind of small things like referring to somebody with a substance use disorder as opposed to a substance abuser. Shifting our language away from like clean and dirty to negative and positive drug tests, those kinds of things, using person first language. It also focuses on skills, right? Training. Healthcare providers say they want to know what to say and what to do. And then structural change also, right? Behavior change can also happen by shifting our policies, our models of care, the way that we structure care, et cetera. Okay, so that's kind of a big overview. Now I'm going to go into the key ingredients research that and actually fed into some of those conclusions. So the background to this research actually came from when the Mental Health Commission of Canada started back in 2010. It had one of its core mandate issues was to address stigma in the Canadian population. So instead of a national campaign, which is kind of a very common way to do it, the Commission decided to take a targeted ground up approach instead. And they identified 4 key target groups, and healthcare providers were one of those 4 target groups. So the way that we went about it is we partnered with various organizations all across the country. We kind of we put out a call for proposals and said, are you offering some kind of anti-stigma intervention? If so, we'd like to hear about it. So we had something like 26 different programs that we ended up signing on with us. And we went about and evaluated their programs using a common metric, a stigma measure that we developed. And the interesting thing is that evaluation results showed variation in outcomes. So I guess that's not so interesting because of course you always expect that, but it wasn't clear why some programs that were like maybe really short were doing really well. And then other programs that sounded really good were like day-long interventions, showed no change at all, or sometimes even went in the opposite direction. So we thought we've got to do more investigation here. We got to figure this out. So we went and launched a qualitative investigation to gain more theoretical insight. And so we went back to all of our programs and we asked them, what is important to have in an anti-stigma program? What are the effective ingredients in your mind? And they said, well, if you want to understand what the key ingredients are, first you need to understand where the stigma is coming from in the first place. And they identified 4 main issues, plus a 5th, kind of half one, which has now come out more strongly. But and the first one is said there's pessimism around recovery, right? That healthcare providers don't really believe in recovery. They don't see it. And what that leads to is this feeling like what they do doesn't matter. There's a sense of hopelessness that what I do doesn't really matter anyway. And so this leads to kind of, so why bother, right? The second one that came out really strongly was lack of skills and confidence. Providers saying, I don't know what to say. I don't know what to do. I don't know what to say to make somebody feel safe in this environment. I don't know what to do to make them feel comfortable, to give them hope. So it wasn't always big, grandiose things that providers were asking for. It was small things. How do I communicate better? How do I work with this patient to keep the relationship on a good level? The third was a lack of awareness of their own prejudices. We heard a lot from our qualitative interviewees that, oh yes, stigma absolutely exists, but it's not in our department. It's over there in their department. So there was a sense of kind of unawareness of where their blind spots were. And this came out as well in the evaluation work we did in the qualitative piece of our evaluations. We asked people, what stood out for you, or kind of what was something that you learned. And we had a lot of feedback saying, I had no idea that term was considered stigmatizing. Or I actually, when that person was telling their story, I realized that I have behaved that way and didn't realize it. So there was a kind of, these aha moments that were coming up in some of the interventions. So just kind of a lack of awareness of where people's blind spots are and where their own prejudices are. A fourth one, tendency to see the illness before the person, right? So the person becomes the illness. And then the fifth one, in that earlier research, it said that all of these kind of roots of stigma, if you will, tend to be exacerbated in situations where you have moral distress and burnout. And this kind of finding, this fifth ingredient has really come out a lot more strongly in recent years, particularly in Canada. Ever since COVID, our healthcare system has experienced way more stress and pressure. So we're seeing this flare up a lot more. So basically what our key informants told us is that this is where the stigma is coming from. So the key ingredients kind of inform these. This is what they're doing, is they're addressing these issues. And there were 6 ingredients that they identified. One was include social contact, specifically in the form of a personal testimony from a trained speaker who has lived experience of a mental illness, right? And that person should be in a place of recovery, right? They should be stable in their illness so that they can speak to kind of a positive trajectory. If you can actually employ multiple forms or multiple points of social contact. And the rationale here was different people connect with stories in different ways. So the more stories you have and the more people you have, the better chance you have at really making that kind of personal connection and getting those aha moments. And of course, people's stories are different, right? So they're going to have different educational pieces that resonate with different people. Your intervention should focus on some kind of behavior change by teaching skills that help healthcare providers know what to say and what to do, right? So this could be language change. It could be some communication skills. It could be, and of course, it has to be tailored to your particular environment and what the needs are. Engage in myth busting. So again, getting at those blind spots. And kind of trying to find those aha moments where it's like, okay, I didn't realize I did that. Okay, I didn't realize I thought that. Emphasize and demonstrate recovery. That was that emerged as being very important. Again, getting that recovery message out there. And then if it is an intervention that is being delivered by a facilitator as opposed to a self-delivered intervention, it's really important to model that person-first language and person-first approach. So basically, your facilitator has to make sure they're walking the talk, right? Okay, so that was our qualitative research. So then what we did is we went back to all of our program outcomes, our evaluation outcomes, and we coded them as yes or no, according to whether or not they had these ingredients. And then we ran it through a meta regression and pooled analysis model. And we found that in fact, the model held up. That programs that included all 6 of those ingredients performed significantly better than those that didn't have all 6. Okay. And then when we did individual regression analysis through with each ingredient individually, we found that 2 ingredients in particular popped, having multiple forms of social contact and emphasizing recovery. So I'll just share with you a couple of quotes here from the qualitative research about the importance of kind of emphasizing recovery. One person here says, many healthcare providers don't really see recovery as possible. They don't know what it looks like because they see people at the height of distress and they don't see when they're recovered. So a lot of stigma comes from frustration and feeling that whatever they're doing doesn't mean anything. And then here, healthcare providers need to look what recovery looks like. It's very important to get them to make that shift. And then again, the piece about social contact. You absolutely have to have the speaker. They're all over it. They love the speakers, and the feedback I get most is we want to hear more personal stories. And then another person said they see it as a reminder, the stories. The aspect they get from it is a reminder that these are real people. They see people at their worst, and they need a reminder that there is a person's life all around it, all around the illness. It's like a refresher to something they already knew, so they welcome it. Okay. And then just a little bit of this was a separate research program that we did kind of much after. It wasn't part of the same body of research, but it was an interesting one that I want to show you because it shows the difference between doing just kind of literacy-based education and social contact-based education. So this was actually a nursing school. And we measured stigma levels before and after the curriculum on mental health and substance use, and then before and after a social contact intervention where a young woman who was in recovery from opioid use disorder came in and talked to the class about her experiences. And then there was an interactive dialogue with the professor about kind of about her experiences, about care and all the rest of it. And you can see here the educational content did nothing, but the social contact actually was quite significant. So 2 weeks of literacy-based education doesn't do anything, typically well, it didn't in this case to address stigma, but kind of 1 class of this personal testimony story really made a marked difference. And here's some of the qualitative comments that the students gave of kind of what came out of that personal testimony for them or that interaction. They said they came away with a much better understanding of the social factors of addiction. They really seeing that individuals are so much more than their substance use. They shifted their perspective about attribution. Right? Really seeing it as an illness as opposed to a choice, which is a hurdle that we often face, right? A tendency to kind of see addiction as a choice. And then, learning about the individual really fostered a greater kind of understanding. And then we also asked these students, would their practice change now after experiencing this intervention? And they said, absolutely. I will approach patients with more understanding and less judgment now. And my interactions will be characterized with more compassion and kindness. So that is, okay, yes. And then the last little bit of our key ingredients research is also important to mention that when we did this qualitative research, We identified the roots of stigma there in, that's the middle of the model. And we identified the key ingredients, and then we went and tested and validated that part of the model. But the other thing, it's kind of important that these are just two contextual pieces, right? This speaks to the content of interventions. But there was also a lot of other things that our key informants told us that was important to think about. There's all kinds of things to think about when you're delivering the program, right? Really the importance of reinforcing key messages, kind of priming the audience sometimes ahead of time, making sure you put them at ease, right? I mean, you don't want to be, you know, the last thing that you want to do, and it doesn't seem to work, is saying, you know, you are doing something wrong and you need to come to some anti-stigma training, right? So really kind of finding, making sure that the messaging kind of connects with what their needs are and where they're at. Sustainability was a big piece too, right? Really working towards that culture change. A one-off program isn't likely to make a permanent shift. You're gonna need some kind of ways to reinforce the message, some kind of boosters, refresher sessions. If you can make the intervention itself sustainable, you know, so that people are kind of always exposed to it, then you're gonna see much more success and more effectiveness. And then of course, you know, kind of preparation and planning too. So there is a larger full model there. And so all of this work is published, and if you're interested in learning more about it, I can direct you to the papers, no problem. So maybe I'll pause there quickly just for a check-in to see if anybody has, and I'll just maybe stop sharing quickly, just to see if anybody has any burning questions before I move on, or comments.
I know there's
Yeah.
probably a lot of folks, but I'm gonna try to get in first. Well, number one, I thought what you said was fascinating. In particular, the justification that's developed when some of these behaviors are kind of ingrained in us, you know, about stigma, those 4 different points that you mentioned, which makes it very difficult and challenging, as you said at the end, about the messaging of how you reach people, because in their mind, they think they're okay. So what I was struck with, as far as when you think about the lack of skills, the prejudice, the pessimism, and so forth, I've been doing a literature review and was looking at countertransference, okay, and transference as it relates to stigma. And it seems that fits really well with that. For instance, if you had a client over the years, had clients that were very difficult, didn't take their medication properly, or relapse often and so forth, you build up kind of this idea about how folks with substance use or mental health challenges are, or something from your family that you saw people having challenges, and how this countertransference maybe reflect in terms of someone's stigma that they may have toward a patient.
Yeah, that's, I mean, I think a really interesting question. And I think it's something that, yeah, we need to be thinking about. Absolutely.
Yeah, because I was
Thank
thinking that could be one of the ways that you maybe part of your education, I guess, that you can look at with providers. So
yeah, I think it's a good way to frame it. Yeah, no, that's really, I'm not familiar with that research, but that's fascinating. Yeah, important. Thank you.
We welcome questions in the chat if folks have them. I do know one that's come up in some of the discussions in anticipation of this presentation was if there's a difference in those stories and the impact of the storytelling, if it's an in-person session like the example you gave, or if it's a video recording or a virtual connection. Could you speak to if you saw any of that?
Yeah, for sure. And, you know, interestingly, in the actual data, like in our, in the programs that we've evaluated, we had both, and we didn't see any difference between in-person versus virtual. So that's really good news, because it means you can record something and then use it, you know, in an intervention, and you don't have to find a live speaker every time. Having said that, participants really like the live speakers. Like, they feel there is that kind of that, you know, of course, that connection in the actual room. whether it's a virtual room or an actual physical room. So there is, I think, yeah. So I think the participants actually enjoyed the live speaker more, but in terms of our quantitative data, we haven't seen a difference, and other research supports that as well.
Thank you. That's helpful. Appreciate it.
There was also a question about what from Grace Marcelo Ramirez, is reading written narratives from people with lived experience another opportunity to show success that shows success.
Yes, and I think yes, reading written narratives, I think like if it's in their voice, right? I mean, in their words, I think it's still, yeah. I mean, we don't have research to show the impact of that compared to the person delivering their own words. But yeah, it would be effective as well in terms of yeah. Okay, maybe I'll carry on then. Okay, great. Okay. Okay, so trauma and resiliency informed care. So this is a second kind of entire program of research that was kind of separate from the key ingredients research. And this research, let me just move forward the slides here. So this research started in the beginnings of it was about 2018. And it was in relation to Canada is also facing a very severe opioid crisis that's been going on for, well, almost a decade now, basically. So in 2018, the federal government approached the Mental Health Commission and asked us to conduct an investigation around stigma on the so-called front lines of the opioid crisis. And then, of course, to offer recommendations. So we undertook a qualitative investigation again to start, where we talked to first responders all across the country, healthcare providers, people with lived and living experience, social care providers, kind of anybody who is kind of on those kind of front lines, as we might describe them. And we wanted to find out, what does stigma look and feel like in this context? What are the impacts of stigma? How is it getting in the way? What are the tension points? Like, where is it coming from? What are the sources of stigma? And then how do we tackle it? How do we move forward? And when you look at this, there's a lot here. I'm not going to go through it all. A lot of it is consistent with the previous research we did around mental illness related stigma. A few new things that are very specific to substance use in this context, and illegal substance use as well. But in terms of, I kind of want to focus on the solutions or the approaches. And basically what we learned here is, again, consistent with earlier research, we need more education, right, around recovery, addiction, treatment, kind of how do we think about these concepts. We need interventions to really focus on building client-provider trust. Again, social contact came up as a really valuable tool, and addressing system gaps and barriers. So addressing kind of structural deficiencies, which is all consistent with earlier research. The two kind of newer things that popped up was providers were saying we need training in trauma-informed practice. This is something that will help us do our job. We believe this will reduce stigma. It will improve the way that we interact with patients. It will improve the way that we care for patients. Or people that we're interacting with, right? And then the other thing that they identified was we need some kind of inward-facing support, inward-facing training to support our own resiliency and to help mitigate burnout. Because one of the things that came out very strongly in this research was the moral distress that I referred to earlier. That people working on the front lines of this crisis, they talked about it's like trying to put a Band-Aid on this big gaping hole that just keeps bleeding and bleeding and bleeding. And so they're leading just to a lot of, again, feelings of hopelessness. They're experiencing their own kind of trauma and vicarious trauma from witnessing overdoses and seeing people die and kind of everything that goes along with it. And so, and then high levels of compassion fatigue as well, where they just start to shut down. So, so those were kind of the two things that emerged that were different in this research. So we thought, okay, can we can we find something that that fills this gap? And here again are some quotes just to kind of give you a flavor of what people talked about in that research. So I think integrating trauma-informed care training, I think it's our best chance at reducing stigma. The cheapest and fastest way to make change would be to just change how we educate ourselves. The education is about how do you provide care that promotes emotional as well as physical recovery and that doesn't do more harm than good. And then here, the burnout. It's creating burnout among the frontline workers, and we're struggling with what to do with our own moral, ethical conscience, and obviously psychological health and safety. And that's one of the training gaps. What kind of resiliency provisions can we look at for individuals to continue their career in the front line? Stress in the workplace leads to social distance, contemplative practices that help to mitigate stress in the workplace, which keep people open, engaged, and more able to deliver care, reduces stigma. So we went looking for interventions, and this is when we came across this one particular intervention called Trauma and Resiliency Informed Practice. It's called TRIP for short. And this is a program that was developed by Fraser Health Authority in British Columbia, in the province of British Columbia. And so we partnered with them and said, can we evaluate your program? Because this program provides trauma-informed practice education, which is exactly what came out of that qualitative research. And it's blended, though, with some resiliency training, particularly mindful self-compassion and some resiliency theory and tools. It kind of takes a shared humanity approach to kind of both of these things, and it's offered over a full day. During COVID, it was adapted to virtual and 2 half-day sessions, and that is still how the program continues. Since the original evaluation work that I'm going to talk about, we've actually, in another research project, that research project in the emergency department, we've taken this program and adapted it for an emergency room environment and tested it there. So it for sure is kind of has legs, and I think you will be encouraged when you see the results here. And then, of course, they also offer a follow-up community of practice to kind of reinforce the skills and kind of keep things going. So that's something that, so this is Fraser Health's program. And they have a story behind their program. Basically, they started offering it as just regular trauma-informed practice, right? Teaching the principles of trauma-informed care to 6 later. And but as they were delivering the program, there were 2 things that they said that they noticed were happening. One was, as providers started learning about trauma, how trauma shows up in people and the effects of trauma, they realized that they had inadvertently harmed clients in the past without even realizing it, right? That they had activated trauma, they had triggered it, they had just kind of not dealt well with things, and they felt horrible, right? And they said, I've harmed patients and didn't even realize it, and now I feel terrible. So that was one thing. The other thing that participants were experiencing is, again, as they learned about trauma and how trauma shows up, they realized that they themselves were experiencing the effects of trauma, and it was showing up sometimes on the job, and they didn't know what to do about that. So they kind of pulled the bus over, so to speak, and kind of went into the literature and researched kind of how can we deal with this, right? This is not a good outcome we want for our educational program. And so that's when they started embedding this resiliency component into the training. And in particular, they brought in the teachings of mindful self-compassion, largely based on Kristen Neff's work, who is another American psychologist, and also some grounding techniques, some breathing techniques, and resiliency theory. And you can see here a quote from a participant who went through the program. I truly understand what the phrase means. You can't give what you don't have. And that is kind of the main theory of change, I guess, if you will, that underpins this program, is the recognition that you can't give trauma-informed practice if your cup is empty, right? So you can't give what you don't have. So basically, it kind of has this combined inward outward facing dimension to it. And here's our evaluation results. So we measured stigma, of course, stigma reduction. In this context, it was stigma related to substance use. And we also measured resiliency skills and self-compassion, because those were two of the main components of the program in terms of like the direct teachings. And then we also measured, we used the professional quality of life scale to measure secondary traumatic stress, burnout, and compassion satisfaction. And I don't have all the bars here, but basically we saw significant improvements in all of those measures. And what is really encouraging is that when we measured again at 3 months follow-up, 3 to 6 months, in some cases, we saw that the gains that we had seen were retained, and in some cases were continuing to improve. So we were really encouraged by this because often, as I said, if you don't have kind of refreshers or this, you can see some regression back to the mean at follow-up. So an improvement in resiliency skills, self-compassion, stigma reduction, all kind of held at follow-up, and measures like compassion, fatigue, and burnout were continuing to see improvements. So we were really encouraged by this. And then in terms of some qualitative feedback, we asked participants, what skills are you using from the workshop? So motivational interviewing, listening more openly, become more of my thought process, identifying when I may be having biased thoughts, learnings on resiliency and all the types of trauma. I use the window of, we teach the window of tolerance, being mindful of my own reactions, rephrasing, language change, right? There's a lot of focus in trauma-informed practice to use more kind of open invitational language, right? As opposed to directional language. Keeping in mind the attitude of non-judgment, changing the language to what happened to you instead of what's wrong with you. Self-care, right? So you can really see this kind of inward-facing, outward-facing kind of combination going on. More empathetic and patient. Okay, so that's kind of the basic of the basis of TRIP, and maybe I'll just kind of carry on because there is a kind of a second part to this research in Fraser Health, and this is where I think it gets particularly exciting. And this is where we start to see some evidence that that embedding that, some kind of programming like this can actually move beyond individual level change and to start to shift cultures of caring and actual structures in healthcare. So right now we're measuring impacts kind of at that personal and interpersonal level, right? That's what all of these outcomes are showing are the providers themselves kind of shifting, right? Feeling more resilient, their stigmas reduced, and feeling more kind of happy, I guess, if in their jobs. And here we have a respondent saying, and being able to offer course and deliver information is one thing. Making the cultural shift and actually shifting culture is a whole other thing. So we were interested to see whether TRIP is making any changes at that kind of service culture level. And so what we did is we identified several, Fraser Health helped us identify kind of several service areas where TRIP really was embedded. The leaders kind of were all TRIP champions. People were being kind of trained in it. It was just kind of becoming kind of an important thing in the service area. And we collected kind of change stories, right? And we did a realist analysis on it, and kind of developed a framework out of it. But what I want to share with you are some of the actual structural changes that that we found. And because what we found is that they were moving from individual level change to actually changing policies, actually changing different kind of structural elements within service delivery. And so here's one example with the discharge letters, right? The discharge letters and then the kind of behavioral contract in a clinic. And he said before the discharge letters were very blunt and not friendly. So I've redone what we used to call the behavioral contract, and it's now called the welcome letter. And I'm working on redoing the discharge letter so that when it goes to a client, it's not like, no, we're not providing you service anymore. But it's like, we haven't seen you in a while. We can't get a hold of you, and we want to continue providing you care. If you need help in the future, please reach out to us and reestablish this. So kind of shifting the whole way that that different things are communicated. You're like reframing it, right? As JC said. And here's another service area where this person said, we're very intentional in the culture. So examples include if a patient missed a number of appointments and all of a sudden showed up, we didn't say, where were you? You've missed all your doses. We have to start all over again. All we would say was, I'm so happy to see you. And we chatted about how we respond, and we were very intentional around that. And then JC again says, somehow I've created a culture where if a client starts having concerns, put a break. And the actual incidents of violence have gone down a lot. So yeah, I thought that was a very kind of important and powerful outcome. So just some examples of the structural changes that we captured when we did this change story study. We saw changes to physical spaces, right? Changes like waiting rooms, clinical spaces, just making them more trauma informed and more inviting. Changes to policies. We found TRIP principles becoming embedded into hiring and interview guides. It became embedded into the culture of conversations with colleagues. So embedded in staff meetings. We had one example where a team was retiring a word a week. And the one example that comes to mind was the term I'm blanking on it, sorry, the term drug seeking, and retiring that and saying they're seeking relief from pain. So kind of switching it out. Greater cross-sectoral collaboration we saw, so different partnerships working, reduced instances of client aggression, improved client retention in some service areas, and changes to intake forms and processes, which you saw examples of there in the previous one, in the previous quotes. So again, this idea of screening in instead of screening out. Okay. And again, this goes back to this kind of larger model of whatever your intervention is, kind of ultimately you want to work towards that culture change, right? Having the individual level results is great. But to really, we're really going to get serious about addressing stigma, we ultimately want to work towards that culture change, right? So sustainability really is key. Right? Some kind of sustainability model and program. Okay. And just, I'm kind of to the end of my slides here, but I just want to highlight a few resources that these are offered through the Mental Health Commission of Canada. They are all available free of charge. There is the one in the middle is a mental health structural stigma training in healthcare. That just, is kind of meant to just kind of provide some awareness and grounding in what we mean about structural stigma. So that kind of institutional level stigma, a quality care framework for mental health, which includes stigma as kind of one of its main dimensions. And then another research project that we did where we kind of interviewed champions and change makers is what we called them, people who were actively implementing interventions that address structural stigma in the healthcare system. And then through kind of their experiences and all of their knowledge, we came up with kind of an implementation guide. So if anybody was, any other groups are interested in tackling structural stigma, some kind of guidelines and resources and tools of kind of what to expect and how to move forward. And I think that's, yes. And my contact information is there, but it can also be provided by the team. I'm going to stop sharing now, and then I think we've got a few minutes left, hopefully, for questions. Sorry if I rambled on a little bit.
Thank you so much. Absolutely wonderful, wonderful information. Thank you. So what questions do we have? We have a few minutes left.
I did have a question related, Dr. Knack, was there any kind of tools that organizations can use to kind of check, look at their readiness to actually embrace something like this? Because, something like this, you talk about cultural change. I know that a lot of folks I know have used words like frequent flyers, folks who go to the hospital, and changing language and all that. That's a big undertaking. But is there any kind of tools that organizations can use about, for their readiness to engage this?
Yeah, that's a really good question. And readiness is something that's important to consider. And for sure with TRIP, that's come up a lot. At one point, they were actually wanting to develop a readiness tool, but I think they struggle with resource and capacity, and so they've moved away from it right now. But I know what they really do a lot of is every time they're going into a new service area is they start with some qualitative. They gather perspectives, right? They just want to hear from people. What's what are the tension points? What's going on? And getting that early kind of buy-in and engagement can really help with a kind of establishing or kind of assessing readiness and kind of where people are at and kind of where the level you need to go in at.
We had a question about the
Thank you.
links to the studies. Dr. Knack, is it possible to share these slides or at least just the publicly available links to, we'll, and just so everyone knows, after the session, we'll send out just an email with the recording and everything. So
Yeah, so I don't have permission from the Commission and Fraser Health at this point to share the slides, but I can absolutely pull together a list of the publications. And then of course the recording can be sent out to everybody. That's no problem.
okay, great. Well, that
Yeah.
marks the hour. So thank you all for attending, and thank you, Dr. Knack, for hosting this session. It's been very informative. And a huge thanks to Dr. Williams and Lisa as co-chairs of the Mental Health Work Group, organizing this and setting it up for the Health Equity Collective.
Thank you so much, everyone.
All right.